but with the specific focus on chronic spontaneous urticaria. Now, this can be quite a daunting topic, and for that reason, I thought I'd make it a bit more practical and discuss this at the hand of a case study. So I'd like you to meet my patient, Mary. She's a 30-year-old female who presented to me with a 5-month history of a very itchy rash. The rash started spontaneously all over her body, and there was no specific reason that she could think of for this rash to be there. Some days she would wake up with her lips and her eyelids being very swollen. And she's a gym instructor, and she experienced that with exercise and wearing her tight-fitting gym clothes, it would make the rash a little bit worse. But she's got no previous history of any allergies. So she presented with typical wheals. These are a rash that has got a central, swollen, palpable area of variable size and shape. It's got surrounded by a reflex erythema that blanches with pressure, and it's usually very itchy, but some patients would also complain of a burning sensation. What's typical about hives is that they would appear and disappear, but the typical single lesion would usually disappear within 24 hours. And when it disappears, it leaves no marks on the skin. And these rashes can come out anywhere over the body. She also had episodes where she would wake up with the lips and the eyelids that's swollen. And this is angioedema, which we've seen before today already. This is usually a swelling of the lower dermis and the mucous membranes. And patients normally complain that this is more painful than itchy. It usually disappears much slower than the hives, and it can take up to 72 hours before it will disappear. It's usually seen in the facial areas, the lips, the eyes. It could be on the hands, the soles of the feet, but it can actually be also anywhere on the body. Urticaria can be classified into 2 groups, acute and chronic. The acute group is usually when you've got hives with or without angioedema that's present for less than 6 weeks at a time. We often see, especially in children, that these episodes are associated with some form of an infection, but it's also in this group that we'd often see an allergic reaction to a food or to a medication. And it's important to try and find the cause for the hives. And if you can find a cause there or an allergen, then the treatment would obviously be to avoid the trigger. The chronic group is classified as chronic spontaneous urticaria or inducible urticaria. Chronic spontaneous urticaria is when you've got hives with or without angioedema for more than 6 weeks, every day or almost every day. And important in this group is that there's no obvious external trigger or factor that we can find as a cause for the rash. Inducible urticaria is when there's a physical trigger present. These are things like cold or heat or pressure that's on the skin and then triggers these wheals to appear. And a nice example would be a patient like this who presented with these linear shaped like hives. And that was due to scratching of the skin. And this is called dermatographism or skin writing, as you can see there on the picture on this slide. But my talk today is focused more on the chronic spontaneous urticaria group. Now, these patients, we see a prevalence of about 1% in the population. There's a higher prevalence in females, and it's seen in all age groups. But typically, the peak incidence is between the age of 20 to 40 years. About 45% of patients has associated episodes of angioedema with their hives. And studies have shown that there's evidence that there's an increase in chronic urticaria in recent years. 50% of patients will normally resolve within 1 year, another 20% within 5 years. However, chronic urticaria can persist for many years in some unfortunate patients. So we suspected in my patient that she's got a chronic spontaneous urticaria. From her history, we couldn't find any obvious external trigger. But it's interesting that a lot of the patients with chronic urticaria do have a component of their symptoms that's being triggered by a physical factor. In her case, such as the exercise and the tight-fitting clothes, that did aggravate the rash a little bit. But Mary was extremely unhappy and frustrated. The itching was affecting her work and her sleep. She was feeling extremely self-conscious to work with patients while she's covered in a rash. And she was already taking daily antihistamines without any effect. So we prescribed for her higher doses of antihistamines while we started to do her workup. But the main question that she was asking is, why is this happening? So the burden of chronic urticaria is frequently underestimated in these patients. If you look at quality of life scores in patients with chronic urticaria, it is similar or worse than patients with other diseases such as atopic dermatitis, psoriasis, or coronary artery disease. This disease is very unpredictable. You will plan something and then that morning you wake up and your eye is swollen shut. It interferes with your sleep due to the severe itching, social interactions, and work performance, and it causes significant emotional distress. It's also got quite a significant cost impact on the patient, on healthcare systems, and on the general society due to the absence from work, as well as a loss in productivity. The assessment of the disease severity and the response to the treatment that you are giving is very important in the evaluation of your patient. And this can be done through quality of life questionnaires, which is validated scores that the patient fills in themselves, such as the Chronic Urticaria Quality of Life Questionnaire and the Urticaria Activity Score. So this is an example of the daily urticaria activity score, where the patient then scores the number of wheals that they get and the degree of itching that they are experiencing every day. And you can monitor then the course of the disease as you start your treatments. An identifiable cause is only found in about 10 to 20% of cases. Patients often come and they suspect that it's some kind of food allergy, something they are eating. And I often see the patients where they've actually stopped multiple foods from their diet because they believe that this is the cause for the hives. But in the literature and studies, we've seen that a type 1 allergy, an IgE-mediated allergy, is a very rare cause of chronic spontaneous urticaria. Pseudo-allergic or hypersensitivity reactions to non-steroidal anti-inflammatories or other drugs or foods may be more relevant. Food additives could aggravate the chronic urticaria, but it's rarely the sole cause of the disease. These patients often also have multiple triggers for their urticaria. And then regarding environmental allergens such as pollen or house dust mite or animal dander, we see that IgE sensitization is higher among these patients with chronic urticaria compared to the general adult population, but these are not the reason or the cause for the chronic urticaria. Factors such as alcohol overuse, excessive tiredness, or emotional stress, or the use of non-steroidal anti-inflammatory drugs are seen as potentiating factors. I usually explain this as it's just that last drop in the bucket that makes it overflow. So most patients who's already got urticaria would have a flare if they're confronted with some of these things. The pathophysiology of urticaria, we know that this is a mast cell-driven disease. The mast cells or the basophils get activated, they degranulate, and histamine and other cytokines gets released. The histamine binds to the H1 receptor in the skin or on the endothelial walls. It causes vasodilatation, increased capillary permeability, and the result is that you get swelling, erythema, and itching. But the exact mechanism leading to mast cell activation in chronic spontaneous urticaria is not completely understood. Studies have shown that there's about 30 to 50% of patients that does have an autoimmune underlying pathophysiology. In 35 to 40% of this group, the patient has got IgG autoantibodies against the IgE receptor, and 5 to 10% of them have got IgG autoantibodies against IgE. So, to just explain this a bit better, the mast cells and the basophils express a high affinity IgE receptor, those green ones, on their cell surface. And then some patients then would have these anti-IgE receptor IgG autoantibodies binding to the receptors, activating the mast cell, and then degranulation with histamine secretion would take place. Or there would be the IgG autoantibodies against the IgE that is surface bound. It will bind to the IgE, here the blue one on the left, and then once again the mast cell gets activated and you get histamine secretion. Another possible mechanism that we think is possible is IgE-mediated type 1 autoimmunity, also referred to as autoallergy. And in these patients, it's postulated that they are having IgE autoantibodies against several serum factors, for instance, thyroid peroxidase. And this theory is supported by the fact that we often see that chronic spontaneous urticaria patients have got an elevated level of total IgE. If we want to work up these patients, once again, as we've heard this morning a couple of times, a thorough good history is very important, together with a good physical examination. Your history is your best tool to try and get to the bottom of this problem and see what's happening with your patient. It's important to look at the time of onset of the disease, the frequency, the duration, any previous tests that the patient might have had or previous treatments he had and what was his response, his own history of allergies or his family history of allergies, his medical history and drugs or medication that he might be taking, social habits, his occupation, any associated symptoms that he might be having when he gets the hives, as well as physical triggers that could lead you to think of a different diagnosis like inducible urticaria. It is important that we do not just do intensive and costly, extensive diagnostic tests on these patients, but rather do our investigations based on the history that we found. So in chronic spontaneous urticaria, the guidelines suggest that the patient should get a full blood count together with an inflammatory marker like an ESR or a CRP. And then obviously you will try and avoid any suspected triggers like medication or something that the patient is taking that you might think is a problem. And then further extended diagnostic test should be based on the history of your specific patient. Maybe specific allergy tests, thyroid autoantibodies, stool or urine for parasite tests. If the patient presents with any atypical features of their hives, then even a skin biopsy could be considered. It's also suggested that routine screening for malignancies is not advised in this type of a patient. So my patient's lab tests came back. She had a normal full blood count, an ESR, and a total IgE levels were normal, but she did have elevated thyroid autoantibodies. She had some atypical features with her skin rash. When they went away, there was some bruising. It was probably due to scratching, but we did do a skin biopsy on her, and the features were consistent with urticaria. So at this stage, she had no improvement on these increased doses of antihistamine. And she was visiting the emergency room almost weekly at night with severe angioedema at times and extensive urticarial rashes over her body. And every time she would be prescribed a course of oral cortisone. So she was basically constantly taking oral cortisone in quite high doses. And I was very worried about the side effects from this treatment. So if we look at the 2018 guidelines of the European Academy of Allergy and Clinical Immunology, they suggest a stepwise approach towards your treatment. So you would start your patients off with a second-generation non-sedating antihistamine. And if they do not respond, you can increase the dose of your antihistamine up to 4 times the normal dose. And these increased doses of antihistamine has been shown in studies to be safe, and you can try them. But even with this increased doses of antihistamines, you would normally only about 40 to 50% of patients will get a good response. The second line of treatment would then be to try and add omalizumab to your second generation antihistamine. So omalizumab is a humanized anti-IgE antibody. And the omalizumab binds the IgE and lowers the free levels of IgE. It also inhibits the binding of the IgE molecule to the high affinity anti-IgE receptor on the basophil or the mast cell. And then it also then downregulates these receptors on the basophils and the mast cells. Omalizumab has been shown to have a very good safety profile and a low side effect rate. And 65 to 80% of patients will respond to this treatment. The last line of treatment, if you've still not got any improvement in your patient, would be to add cyclosporin. Cyclosporin is an immune suppressant, but it's got a higher rate of side effects, and it's very important to monitor the blood pressure and the renal function if you treat your patient with this. There you've also got about a 70 to 80% response in patients. And with the combination of all three of these treatments, there would be about 7% of patients left that still does not respond. Topical corticosteroid creams are not effective in chronic spontaneous urticaria, but oral corticosteroids are known to be effective. And they are often used out of frustration or desperation because the patient says it is all that works for them. However, it's got a high potential for adverse side effects, like we all know, and it really should not be used as a routine treatment in chronic spontaneous urticaria. And it should only be kept and used for those acute exacerbations and then for the shortest period of time at the lowest effective dose. Other drugs such as the leukotriene antagonists or, for example, montelukast was previously on the 2013 guidelines, but it has been removed now in the 2018 guidelines due to the low level of evidence of its efficacy in CSU. And that goes the same for other drugs such as the H2 blockers, colchicine or tranexamic acid. So my patient Mary was started on omalizumab injections. We gave her 300 milligrams subcutaneously every 4 weeks, which is the dose that is safe and effective in chronic spontaneous urticaria. And this dose is independent of your IgE levels. She was observed in the rooms and she didn't have any side effects and she went home. And recently I followed her up, and this has been the remarkable change. She's much better. Her urticaria is controlled. She had 4 injections by now, and she's currently a much happier and friendlier patient. She's enjoying her life and she's back at work and it's going well. She does not have any side effects. So we had a good outcome there. As a take-home message, I'd like to say that chronic spontaneous urticaria can be a very confusing disease for the patient and the doctor both. Remember that it's got a high impact on the quality of life of your patient. I find it helps to explain the nature of the disease to the patient. If they understand that this is not a typical allergic reaction, if they stop eating milk or egg, then the hives will go away. It already takes us a long way. Take a good history from your patient and only do the relevant investigations based on the history that you've got from your patient. Teach them about the potentiating factors and they should try and avoid these, and use the stepwise approach that's given to us in the guidelines. If your patient doesn't respond to antihistamine, it's safe to use an increased dose up to 4 times the normal dose. But if you're still not getting a response, we really should consider to put these patients on medications such as umalizumab or cyclosporin. I thank you for your attention. I hope you enjoyed the talk.
Thank you so much for the talk. Brilliant presentation. The next talk will be by Dr. Kiragu in Kenya, who will be talking about HMO and allergies. Elizabeth, over to you.
Sheho, please allow me to share my slides if I can.
Yes, you may.
I don't, yeah? Oh, thank you.
Yeah.
Can you see my screen yet?
We can see you and we can hear you.
But can you see my slides?
Not yet.
Okay, just a minute.
We would like to thank the NNIA for making this talk possible.
Sheho is asking me to revoke my screen sharing permission.
Yes. So start sharing and allow.
I've done that, hey? I'm sorry for the technical issues. Okay.